السلام عليكم جميعا ورحمة الله وبركاته. بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا ونبينا وحبيب قلوبنا محمد وعلى آل بيته الطيبين الطاهرين. Thank you for joining us this Saturday morning for another Faith Community Health Initiative presentation. Before I introduce the guest speakers, I just want to give a brief introduction to the committee for those who are first-time attendees. My name is Ahmed Awada, and I am one of the board members of the Faith Community Health Initiative located here at the Islamic Institute of America. Faith Community Health focuses on the intentional care of the spirit, as well as the promotion of holistic health and prevention or minimization of illness within the context of a faith community. We have an amazing committee consisting of multidisciplinary health professionals. We all have a passion for helping improve the health and well-being of our faith congregation through providing resources, education, culturally sensitive trainings, and community engagement. We will have 3 tracks to address the needs of the community: a wellness and prevention track, a mental health track, and an end-of-life and chronic illness track. Our mission is to advance the physical, mental, and spiritual health of the Muslim faith community so we can grow a strong, healthy community. And everyone should have received a survey. If you can fill that out on your way out, we would greatly appreciate it. Our session today is titled What to Do with a Cancer Diagnosis, presented by Dr. Rabbie Hanna and Dr. Zaid Al-Wahhab. So we will begin with our first speaker. Dr. Rabbie Hanna did his OBGYN residency at Wayne State University and Detroit Medical Center, followed by fellowship in gynecologic oncology at the University of North Carolina, Chapel Hill. He is currently a staff gynecologic oncologist starting at Henry Ford Health and associate clinical professor at Wayne State School of Medicine. Please help me welcome him with a loud salawat ala Muhammad wa ali Muhammad.
Assalamu alaikum wa rahmatullahi wa barakatuh. Allahumma salli ala Muhammad wa ali Muhammad. So me and my colleague and brother, Dr. Zaid Al-Wahhab, we've been friends for, mashallah, almost close to 30 years now. Both of us are gynecologic oncologists, so we deal with a lot of cancer diagnosis. And we have seen that one of the things that we have with a lot of just our community is how to deal with this cancer diagnosis and what to do, what are the backgrounds that we would expect or we would want people to understand and know. So today we will hint to a lot of things that we use and terms that we use and give a simple understanding of what we mean by some of the idioms that we use or words that we use. And we'll kind of allude to some myths or ideas that are in the community about cancer. Next slide, please. So basically, what is cancer? When we talk about cancer, it is an abnormal growth of cells. So usually what happens is that our cells, when they grow and create the organs, or when they repair themselves during our normal life. So for example, if we think about having an incision, a cut on our skin, the cells grow with each other, okay, until they reach a point where they know they should not grow anymore. Now we see the scar, that's overgrowth. A more exaggerated scar is the keloid, okay, and that's even more gross. So that's how we think about cancer. Now, but with cancer, there's unlimited growth, so it keeps on growing and growing and growing. It could cause a spatial effect where it causes pressure on the surrounding systems. It could affect it from a space standpoint. It could affect it from a pressure standpoint. For example, if the tumor is growing on the bowel, the intestine, and then it blocks the intestine, or it could affect the function also. For example, blood cancer would affect the function of the blood cells. Next slide, please. So here, for example, this is the center. This is where the tumor cells are, and these are the normal cells. Next slide, please. Now, with cancer, well, not all cancers, but with some cancers, we have what we call the precancerous lesion. So from left to right, we will, Yes, thank you, Habibi. These are normal cells. Here we see one cell is becoming abnormal. We still don't call this cancer. Here we see more abnormal cells, but they don't cause any effect, and they're still not causing cancer. But pay attention to this, what we call the basement membrane. It's kind of a thickened tissue between these two levels of tissue. At this level, here, this is what we call precancer or dysplasia. If we can identify this beforehand and remove it, then we have prevented cancer from growing in that organ. Now, if we miss it for some reason or another, and it continues to grow, then it goes into forming actual cancer. And the management could become different based on the organ. Next slide, please. Now, screening. So we have the ability for some cancers to do a test to find the precancer lesion and then prevent cancer from happening. Next slide, please. For example, cancer of the cervix, اللي هو عنق الرحم. We are able to see the cervix on examination. We swipe it with certain instruments, like a brush, and we examine the cells under the microscope. If there's any cell that represents a precancerous lesion, then that tells us to go in and possibly take biopsies or anything. So that's one form of screening. Now, screening has guidelines. The guidelines are based on what we see nationally. For example, in America, we have certain guidelines. We start screening for cervical cancer at a certain age, and so on. Next slide, please. For example, we have the colonoscopies, الناظور. Basically what it is, a camera goes inside the anus and it goes all the way up and examines the entire colon. And when the surgeon or the gastroenterologist sees a polyp or a lesion, they will take it out. Most of the time, if it's a precancer, then that could cure it. Or if it's a cancer, they might do something else. Now, of course, this one also has guidelines. For example, for colonoscopies, anybody who's 50 years old has to have a colonoscopy. If it's normal, it's repeated every 10 years. Some people come and say, well, I want to do it every year, so I make sure there's no cancer. It makes sense logically or perceptionally, but there's no data to support that. So we rely on what is published. Next slide. Now, how do we diagnose cancer? We could develop a suspicion of a cancer presence by physical examination. Okay? If I examine the abdomen and if there's a tumor somewhere, that will give me a sense of there's something abnormal. Then that might lead me to biopsies. If I see the cervix and there's something on the cervix, I will take a cut of that lesion and that will give me an answer if it's a cancer or not. I might use some blood work that could give me a reflection. Is there cancer? Is there not cancer? If there is, what is my suspicion? Some cancers rely solely on the blood work numbers, the values, and others don't. So again, I'm just giving a general idea of these. And we might do radiologic tests, X-rays, CT scans, MRIs, PET scans. One misconception, people think that the PET scan, which is the most expensive one of these, is going to give the best results. Now, there are some cancers where the PET scan is what we need, and there are other cancers where the PET scan has limited value. When I say limited value, we say when you compare a PET scan to a CT scan for that cancer, is there any information that would change what I do? That's what we rely on. So because we don't want to order expensive tests that don't make a difference in what we do. Next slide, please. So treatments of cancer, it's all dependent on where the cancer is. It could be a combination. It could be just the use of surgery. It could be a combination of surgery then radiation. It could be a combination of chemotherapy and radiation without surgery. It all depends on what type of cancer, which organ is affected, what stage the cancer is coming from. Next slide, please. Now, when The patient and the family go to the doctor and they talk about treatment. We always talk about what is the right treatment to do. So this takes us to the term, what is standard of care? What that means is that I expect if this patient goes anywhere in the country, they will give them the same recommendation of treatment. Okay? That's what we call standard of care. And this is where we say we don't recommend treatments on personal experience in the general sense of cancer unless we have certain unique circumstances. For example, if I have somebody who comes to me and we think we have an ovarian cancer, we know nationally and internationally, as of now, as of today, the best treatment is surgery followed by chemotherapy. Let's say that patient goes to Dr. X in a different place, and that person says, in my experience, you're better off doing chemotherapy only. That is not considered standard of care. Okay? So when a patient goes and asks for treatment, one of the questions that we ask is that standard of care? Meaning, are you relying on national guidelines that direct you towards the right treatment without using your personal experience? There might be some different options of standard of care. That's where the personal experience might be reflected based on the data locally and nationally. We also have what we call clinical trials. A lot of people think of clinical trials as a negative option because they think they're experimenting on them. And this is where we have to break down what a clinical trial is. Basically, a clinical trial, it means that we are going to try something new. Now, most clinical trials, we look at a standard of care option and compare it to a standard of care option plus something experimental. Now, each scenario, each disease state, if it's early diagnosis, an initial diagnosis, or if it's a recurrence, those options in that clinical trial might change. But the majority of time, we revert to clinical trials when we believe the option of experimental drug will make a difference for us. And there are some clinical trials that we have evaluated where we believe that we say, you know what, we don't believe this is appropriate care, so we don't use those clinical trials. Next slide, please. One of the very, very important issues is when we have a diagnosis of cancer is you have a good oncology team. Now, you as a lay person, how can you evaluate if that oncology office is a good office for you to follow or not? Or should you really take your care and go somewhere else? So, it begins from scheduling. You will have a good sense of how organized the office is in scheduling your appointments, in preparing the paperwork for your appointments, and doing their homework to see you. For example, when I have a new patient come to me, my office arranges all the paperwork, gets all the studies from the referring physician, and I have it beforehand before I see the patient, because I want to study about the patient before I meet that patient. So, and then also look at what are the components of that office, meaning, who, for example, when you come in, if somebody comes and sees me or Dr. Zaid, who's the team? Is it just him by himself? That might be too much. There might be too much strain as compared to having nurses and nurse practitioners or assistants. And do we have tumor boards? What that means is, am I going to meet with other people in my specialty, in my location, and talk about patients, or am I just going to give my personal opinion? That's very important so we can reach a consensus opinion. And of course also, is that office going to tell me how I can communicate with them? What if I have a question? So if my patient leaves the office today and at home they thought of 5 questions, do they have to make an appointment? Can they call? All of that is going to be essential because the communication between visits is very, very important so we don't lose any information. And then also, a lot of people think or believe that if they come and see me and they want to get a second opinion, that I would be insulted by getting a second opinion. The majority of us, we welcome second opinions, we welcome third opinions, because our goal is to serve the patient and not our ego. So, next slide, please. This segues to my brother, Dr. Zaid al-Wahhab. I'm going to introduce Dr. Zaid al-Wahhab because Ahmed left the room. Basically, Dr. Zaid al-Wahhab finished his residency in OBGYN at Wayne State University, Detroit Medical Center, and then that was followed by a fellowship in gynecologic oncology at Wayne State University at Carmanos, and then he is now a senior gynecologic oncologist at Beaumont, and he's the associate professor at the Oakland University Beaumont Hospital, right? Well, mashallah. Yeah, تفضل عمي. I call him Ami because I look up to him, so it's.
Thank you. Okay, so next part of the lecture, I'll be talking about misconceptions and myths about cancer that commonly we get asked about almost every day or every week in our offices. Can we have next slide, please? So, is cancer a death sentence? No, the answer is no. Can you click on it? Next. Next. So it's not. The most important thing with cancer diagnosis is to be able to diagnose it earlier. So currently the survival has improved dramatically. 90% of the patients with the most common cancers like breast cancer or prostate cancer actually survive more than 5 years after diagnosis. The most important thing with cancer is be able to diagnose it early. The earlier the diagnosis of cancer, the more chance of cure and the less chance of this cancer coming back again in the future. So survival has improved dramatically in the last 20-25 years, and it's getting better and better every year with new chemotherapy drugs and new medications and treatments for cancer. Next slide. Will eating sugar make my cancer worse? It's a very common question. I get asked about it almost every day. Yeah, I get asked about this question every day. Okay, should I stop sugar? Will sugar cause my cancer? If I stop sugar, can I cure my cancer? So the answer is no. Cancer cells, like any other human cell, need sugar to divide and multiply and grow. But at the same time, other cells in the body also needs the sugar. So let's assume theoretically we stop eating sugar for a year. Okay. At the same time, we check our blood sugar every day for this entire year. Blood sugar will stay normal level in the blood. Okay, despite that. Why? Because we have our liver, which is a very important organ in our body, and if we eat fat or we eat protein, we'll automatically sense there is less sugar in the body. We'll switch that fat and protein into sugar. So even if we stop eating sugar, sugar will be a normal level in the blood. The only organ in the body that uses sugar only is actually the brain cells. And if you know diabetic patients or patients with very low blood sugars, they will faint because there is no enough energy to the brain. So it's a very common myth, get asked almost every day, and stopping sugars will not change anything with this. Next one. Artificial sweeteners, are they dangerous? Are they healthy? The answer, we don't have evidence for that. Can you click on it? So there is no evidence. These are all different types of sweeteners, Splenda, Equal, all of them they have been studied so far. None of them has been known to cause carcinogen or cancer by themselves. So far they are safe, unless we have more evidence in the future. Next slide. Is cancer contagious? So if someone diagnosed with cancer, a family member or a friend or a partner, will I get the cancer from that person? Can you click on it? So the answer is no. Okay, cancer cannot spread from one person to another. The only theoretical way of cancer going from one person to another is organ donation. If someone is donating a liver or a kidney to another person and has cancer cells in it, theoretically that person can pick up that cancer. And because of that reason, patients who are diagnosed with cancer, even if they are cured, they are not allowed to donate their organs while they are alive or they are dead. Okay? But at the same, can you click next slide? At the same time, there are some viruses that can spread among humans and bacteria. Click again, please. Yeah. So, for example, human papillomavirus, HPV virus, it's a virus sexually transmitted between partners, and there is hepatitis B and hepatitis C can be transferred also sexually transmitted or by IV drug abuse. The virus can spread from one person to another. It doesn't bring the cancer with them, but can cause the infected person to get cancer, cervical cancer or liver cancer. Next question. Can cancer surgery or tumor biopsy cause the cancer to spread? Also, is a very common misconception that if I go take a biopsy from that cancer, would I cause it to spread to other organs? Well, it depends which kind of organ it is. For example, an ovary, if we need to remove it, I wouldn't biopsy it. I would remove the whole ovary, put it in a bag, and then send it to the lab. So the answer is no, but surgeons are well trained and be careful to prevent the spread by putting a needle to take a biopsy or by removing the entire organ and putting it in a bag before removing it. So, will cancer get worse if exposed to air? You take the cancer out or you open the patient's belly or lung or any tissue, will this make it worse? The answer is no. Cancer, when exposed to air, will not grow further, will not get bigger, it will be the same. Next question. Are there herbal products, a'shab, can help to cure cancer? The answer is no. Currently, we don't know. There are some Chinese medicine, people think it may cure cancer. Just keep in mind, a lot of chemotherapy drugs, a lot of them actually are extracted from plants. So some chemotherapies are actually, we got them from plants and then process them and calculate how much the dose we can get. The problem with herbal medicine is you don't know what's the dose of that drug. A little bit sick today. So we don't know the dose of the drug. Plus, another problem with taking herbal medicine, a'shab, while getting treatment, for example, chemotherapy or radiation, it can cause more side effects from those medications or radiation. It can block the effect and make that treatment not effective by using the herbal medicine and a'shab at the same time. So currently, we don't have specific herbal medicine that can cure cancer. Next question. If someone in my family had cancer, will I get cancer? So sometimes, for example, breast cancer, colon cancer, the question will be, can I get the cancer also? The answer is not necessarily. Why? Because actually about 80 to 90% of cancers are sporadic, we call them. They are not inherited by families. Okay? Only about 5 or 10%, maximum 20%, depends on new studies, can run in the family. You can suspect there is something going on in the family if multiple family members, the first, second degree relatives, and they have the same cancer. For example, multiple women in the family, they have breast cancer, or there is colon cancer, or ovarian cancer. Those patients, it's recommended that family members who had cancer do genetic testing to know if there is something running in the family. But actually, 80 to 90% of cancers are not hereditary cancers. Next question. Another common one is using deodorants. Will it cause breast cancer? The answer is no. We don't have evidence right now. Next question. Excuse me. Using hair dye, صبغ الشعر, will it cause cancer? The answer is no. But there are studies have shown that barbers get exposed to a lot of chemicals. الحلاقين may have an increased risk of bladder cancer. Next question. Is cancer a man-made modern disease? I get asked this a lot. Was it there before? هل كان موجود قبل? Or now because of all the technology we have, people are more getting cancer. Actually, it's not. There are evidence even in checking bones of dinosaurs that some dinosaurs from old relics, they had bone cancer in them. There are relics from Egypt and Greek. Those people had cancers. There is an old hieroglyph, مخطوطة hieroglyphية, Amenhotep, he's one of the engineers who built one of the big pyramids, actually describing a female patient with breast cancer. In a way, description, a mass, it's getting deep, but he didn't have a treatment for it. Yes. Correct. Yeah, for two main reasons. First reason is we're able to diagnose it now. Okay, so the microscope was discovered 100 or 150 years ago. So when I have a tissue, I can look at the microscope and I see cancer cells. Okay, 200, 500 years ago, we didn't have this test to know that. Okay, and the other reason also, about almost till the last 100 years, actually, people used to die from other reasons. Famines, maja'at, harub, infections. يعني simple flu, influenza in 1915 killed millions of people. For example, cholera, typhoid, plague, يعني all different types of infections. So بدينا نعالج الأمراض هذه، الأمراض الالتهابات، حروب أقل، أسباب أخرى للموت راحت. الإنسان يعني our life expectancy getting longer and longer. So we're picking up more cancer because most of the cancers actually happens in more advanced age. يعني the older we get, the more risk of having cancer. So that's the reason. I mean, it could be someone died, for example, 300 years ago, for example, and had an infection, but the cause of the infection could be cancer. بس اكو evidence يعني حتى بالعظام الديناصورات مكتشفيها انه اكو بها كانسر قبل الانسان، او حتى عند الفراعنه او عند اليونانيين اكو evidence انه كانسر كان موجود ذاك الوقت وليس it's a modern disease. Next one. So hookah smoking, is it safer than cigarette smoking? So cigarettes, الجيجاير, is the most common preventable cause of cancer and heart disease death. We know very well. It's very directed to a lot of cancers of the body. There is a misconception that hookah, the water pipe, argila, less risky than that. Okay, next slide. So it's very common. Actually, 1 in 5 college students now in this country, they smoke a different type of hookah. You can see here, like 60 minutes of hookah smoking is equal to 100 or 200 cigarettes smoking directly. So now we have more exposure to tobacco. Do you know how many carcinogens, how many chemicals cause cancer in one cigarette? 60. Okay. يعني 60 مادة كيميائية بالجيجارة الوحدة، كل وحدة من عندها وحدها تسوي كانسر. 60 وحدة سويها. Now الهوكا, social smoking, sitting, you don't know how long you've been there, but a lot of studies have shown ساعة من تدخين الأرجيلة يعادل 100 أو 200 جيجارة تدخين. Okay. Now there are no new studies have shown لأنه يستعملون المي بالأرجيلة. المي يذوب هالمواد المسرطنة يخليها تمتص أكثر من الرئة فتسبب السرطان actually أكثر. So بعد أخطر. So إذا مو بنفس خطورة التباكو الجيجارة العادية وإنه قد يكون actually worse than that. Next slide. So vaping, another problem now happening these days for the last 10 days. So e-cigarettes, electronic cigarettes, الجيجارة الإلكترونية. The theory behind it is بدل ما ادخل جيجاره وانا مدمن على النيكوتين، ليش ما استعمل النيكوتين وادخنه بجيجاره الكترونيه؟ So شنو بالالكترونيك سيجارت هي؟ So شوف انواع اشكال الشارجبل ones والباتري ريبليسمنت ones. شنو السائل اللي يستعمل بالجيجاره الالكترونيه؟ So has glycerin in it اللي هو ماده مذوبه كيميائيه. has propylene glycol, basically antifreeze مال السيارات نفس الترتيب على مود يذوب النيكوتين والنيكوتين ومي وياه وبعدين طعم نكهه معينه. حاليا الاي سيجارتس تقريبا اكو يعني 65 different flavors. So the problem we have الجيجاره الالكترونيه was they start making it in China actually in a way to replace على مود المدخنين على الجيجاير يتركون الجيجاير ويحولون على الجيجارة الإلكترونية على مدى إدمان أقل. المشكلة اللي صارت أنه طلاب متوسطة إعدادية كليات they start smoking it more frequently. ما يعجبك هذا الفليفر عندي 65 فليفر غيره. بكل الرائحة وبكل الطعام وبكل الأنواع المختلفة. Next slide. So هذه تركيب الالكترونيك سيجاريت او الجيجاره الالكترونيه. اكو باتري، الباتري اكو هيتر هنا بهالمنطقه. زين الهيتر يرفع درجه الحراره الى 120 فهرنهايت تقريبا، فبيسكلي يحرق الفيبر وبعدين يطلع دخان من الفيبر ويدخنون الفيبر هذا. So العمليه كلها حاليا لانه هي شغله جديده, it's very new thing, we don't know a lot about it, but we know a lot of those patients or people who smoke e-cigarettes eventually wants to crave more nicotine later on in life, and they have more risk of becoming real tobacco smoker later on in life. So actually the goal of preventing smoking actually makes it worse. Later on in life يحتاج الجسم نيكوتين أكثر فيقوم يدخن جيجار إلكترونية ورا 15 سنين يقوم يدخن جيجار عادي. فيفتح طريق إلى تدخين الجيجار وأسبابه. اكو حالات حاليا قبل شهر شهرين اكو حالة او حالتين بميشيغان مرضى يموتون بسبب الجيجارة الالكترونية. ستيت اوف ميشيغان اذا تعرفون حاليا مسوي يعني الجفرنر مال ميشيغان مسوي سسبنشن كومبليتلي على الفليفرد الكترونيك سيجاريت رايت ناو. ساكو بها قضايا قانونية حاليا ما نعرف هواية معلومات عليها لانه فد شيء جديد. الجيجاير صار 100-200 سنة الناس تدخنها, عندنا معلومات اكثر. The e-cigarette is a new thing. Okay, next slide. So, treatment of cancer. علاج الكانسر. دكتور ربيع راح يحكي شوية وبعدين I will follow about treatment for cancer. Okay, question. It's the same risk, second hand smoking. يعني إذا واحد يقعد بمجلس والناس تدخن أرجيلة بس هو ما يدخن, هو حالة حالهم دا يدخن نفس الوقت. أو بالبيت نفس المكان. النيكوتين يعني هل 60 مادة المسرطنة بالجيجاير تلزق على المخاديد, على الفرش, على الملابس, ياخذ الجسم واحد. أي بعد. Yes. Yeah. We haven't started that part yet. Okay. Anti-cancer treatment. Okay. We don't have evidence that they have cancer effect. B17. Yeah. اللي هو يعني المادة اللي داخل السيد هي actually cyanide. Yeah. فهل هو cyanide هل هو safe يعني مادة سامة. Yeah. We don't have evidence, I would say, right now on the role of it. هاي المشكلة. There is no research to prove it's working. Okay. So, treatment for cancer. I mean, the main treatments for cancer, there are 4 main things. Surgery, جراحة, كيميائي, chemotherapy, radiation, إشعاع, أو علاج بالهرمونات. بعض أنواع الكانسر تتحسس للهرمونات, مثلا سرطان بروستات, الصدر, الرحم. So sometimes part of the treatment we add hormonal therapy at the same time to block the effects of it. Treatment can be different from one cancer to another, depends on the stage of the cancer, where did the cancer go. So sometimes surgery, شيل الكانسر, remove it surgically. Sometimes a chemotherapy, أدوية كيميائية. أدوية كيميائية همينة تختلف من ورم إلى آخر استعمالاتها, وحتى حسب درجة انتشار المرض نفسه بالتحديد. إشعاع قد يكون ممكن يستعمله, مثل الفوتونات, الإكس راي, بروتون, إلكترون can be used على مود نحرق أو ندمر الخلايا السرطانية. المشكلة عندنا بالكيميائي, الكيموثيرابي والراديشن, لما ياخذ الجسم it destroys also normal cells in the body. So most of the side effects related to the treatment actually related to damaging other normal cells growing in the body. يعني hair loss can happen, diarrhea, bladder problems from radiation, discharge, infections can happen from them. Now, those treatments has been advanced a lot in the last 10, 20 years, and they became more targeted, more focused to target the cancer cells alone instead of destroying or damaging the other parts of the body. حتى بالradiation هسه صار computerized, CAT scan, 3D view على مود ضربة الإشعاع تكون محددة على مكان الورم وتقليل الضرر على الأعضاء اللي حول المكان الورم. Want to talk more about treatment? Okay. Questions, Asila? Yes. Okay, it's a good question. Surgery إذا المكان محدود. Okay. يعني مثلا افترض سرطان بروستات. Okay. إذا سرطان البروستات already منتشر إلى العظم، أنا ما راح أروح أعمل عملية كبرى وأشيل بس الورم اللي بالبروستات خلال فترة.
people who are socially isolated, there's research that shows that their genetic material becomes shorter and shorter over time. They die faster. People who are more socially attached to other people surrounding and active, those chromosomes or genetic material stays longer. Same thing with cancer patients. I can tell you from our experience, when we see a patient who's fighting cancer, they do better when they have a good social environment, and also if they are well attuned to their faith system, whatever it is. Um, a lot of people, even just simple yoga and meditation makes a huge difference.
Any other question? So there was a slide actually I removed about plastics and microwave. So if the plastic says it's microwave safe, it should be okay. Okay. By using a microwave is just heat. So you can put that piece of plastic in the oven and cook food with it. That plastic will melt and will become part of the food and may have carcinogens. Those who are microwave safe, they should be okay. Foam is no. You can't use foam in the microwave, no. No. Yeah, you can't. It's better not to put anything hot in a foam. Or even don't put it in a microwave.
And here again, when you break it down, what are you microwaving? So if you're microwaving, for example, your food that you made that is healthy, you're just using the physical factor of the microwave to heat it up. Now, but if you're microwaving pre-packaged frozen food, which in itself has a lot of problems, that increases your risk of having problems and potentially cancer, just because that food is not healthy to start with. So it's not the function of the microwave, it's the function of the food that you're eating. Yeah, the microwave is safe. Yes. That's not good. It's not recommended. No. No. Yeah. 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 And remember, so when you look at the microwave design, it shields the surrounding from the wave that is coming from it. Yes. Yeah. Yes, sir. So really it relies on multiple factors. So if, let's say for example, if we have a patient who has a growth on the ovary, okay, we will see the examination and how that growth feels. Might do an ultrasound, and that would give us some information that hints us towards this most likely looks benign or most likely concerning. We might also use additional blood work to help us there. And that gives us an idea of what should we do. Should we go ahead and remove the ovary or not to confirm it's cancer or not? And that relies also on other variables. How old is the patient? What symptoms does she have? What family history does she have? So there's a lot of variables, but I can tell you nowadays we are very lucky to have a lot of advanced techniques that we can use to help us differentiate what is what. But there are a lot of times when we don't know what it is, and we can't go put a needle in it to see what it is, because if I put a needle in it, I have two possibilities. I might go to an area that doesn't have cancer and will give me a false result that I can't take true. Or if there is cancer, I might spread that cancer locally. So we might say the only way to do this is to go in surgically and remove that organ, uterus, ovary, bowel, whatever it is.
So it depends on what type of cancer. So The best way is definitely doing genetic testing. So the best way of doing genetic testing is on the person who has cancer. يعني الشخص اللي عنده سرطان هو يسوي الفحص الجينيتكس to know. لأنه it's more like fishing in the ocean. مثل واحد دا يصيد سمك بمحيط لا يحصل سمكة لا ما يحصل سمكة. أكو آلاف أو مئات الآلاف من الجينات وآلاف من الجينات المسرطنة اللي موجودة. إذا أكو family history for example مال خلينا نقول breast cancer in the family أكو عيادات مال genetics يسموها genetic counselors يسوون خريطة يعني family tree مال شجرة العائلة وحسب هذا calculate أكو risk يسموه risk tool شوف إيش قد أكو risk بالعائلة أفراد العائلة مثلا they can have breast cancer إذا risk is high يسوون فحص دم blood test to check for the genes for cancer. Okay. Yeah. بس الأسهل طريقة للمعرفة الشخص اللي عنده كانسر هو يسوي الفحص. فإذا بي بوزيتيف يعني هنا بأمريكا الفيرست ديجري ريلاتيفز يعني اللي علاقة الدرجة الأولى كلهم يعملون التشيك اب على هذا الجين سبيسيفيكلي. يعني بدل ما واحد فيشنج اوف unknown عرفنا هو هذا الجين عند هذا الشخص فنشيك بس هذا الجين عند كل المرضى يعني الأقارب الدرجة الأولى عند هذا الشخص. That's the best way to screen for cancer.
مرات يجينا أسئلة, so sometimes we have questions that, for example, I have a patient who says, I am very scared of ovarian cancer. My friend just died of ovarian cancer. I want to go and remove the ovaries. Okay? So that's an emotional response, right? It is our duty to come and say, do I have anything in that person's history that increases her risk for ovarian cancer? And if I do, is removing the ovaries a good idea or not? For example, if I judge that person's chance of developing cancer based on using certain tables is 8%, and she's 40 years old, and if I remove her ovaries, I've eliminated the 8% chance of developing cancer, but I gave her 100% chance of becoming menopausal, which has negative effects on her life. And we know women who are 40 who take out their ovaries that are not cancerous, they die sooner than women who save their ovaries. So there's a give and take, and that's why we're very, very careful here to make the decision an educated decision and not an emotional decision.
Any other questions? Okay, thank you for inviting us.
Thank you so much. Allahumma salli ala Muhammad wa ali Muhammad.
So I didn't give a chance to give the background on Dr. Zaid. He did his residency at Wayne State University and Detroit Medical Center as well. He eventually did a fellowship in gynecologic oncology at Carmano's Cancer Institute, and he is currently a staff physician at Beaumont Health, Royal Oak, and Grosse Pointe, and associate professor at Oakland University, William Beaumont School of Medicine. I want to thank Dr. Zaid al-Wahhab and Dr. Rabbie Hanna for that great information. And I know our turnout here wasn't great, but online, alhamdulillah, we have over 400 viewers. So this was a pilot, let's say, for future events like this, and we want to let everybody know here and all our online viewers that inshallah we will have more programs with Dr. Rabbie Hanna and Dr. Zaid al-Wahhab. And thank you guys so much for coming. Wassalamu alaikum wa rahmatullahi wa barakatuh.